A very good morning. I will talk about refractory ascites and newer concepts in the management of this entity. So this is going to be the outline. So I'll start with the definition, which we all know, that refractory ascites is the ascites which cannot be mobilized or the early recurrence of which, that is after a therapeutic parasynthesis, cannot be prevented by medical treatment. And there are two phenotypes: diuretic resistant ascites, where the ascites does not respond to a dietary salt restriction and intensive diuretic treatment, and which is up to spironolactone of 400 and furosemide of 160. But we all know none of us are using this high dosage of the diuretic for the control of this ascites. And what we more commonly see is the diuretic intolerant ascites, where the patient is intolerant and develops several complications related to the diuretics, and you're not able to optimize the diuretics for the control of ascites. Now, the pathogenetic basis, very quickly, we know about the cirrhosis. There is obstruction to the portal flow, portal hypertension, shear stress on these splanchnic vessels, and the production of the local vasodilators, which causes splanchnic vasodilatation and a decrease in the effective arterial blood volume and activation of the various vasoconstrictor systems. And this results in the excess fluid accumulation, sodium retention, and this leads to the development of ascites. And with the severity, in the natural history, this refractory ascites is seen later on, where there is intense renal vasoconstriction also, and sodium and water retention. And what is, again, very important is that now we also know that systemic inflammation, and this is particularly seen in acute and chronic liver failure, where you see that there is a rapid onset ascites which develops very quickly in these patients, and this is predominantly due to the intense systemic inflammation driven by the damage-associated and the pathogen-associated molecular patterns. And the gut dysbiosis is something which remains to be explored in this context. So coming to the management, we know about the etiology management is the primary of, it's very important, because if you do not manage the etiology, you'll not be able to control the ascites. And different etiologies, as I've listed down here, we know that etiological management, but in the context of NASH, which we see more commonly, it is important that we assess the other organs as well, because in these patients you can see ascites which is contributed by cardiac dysfunction, kidney dysfunction, and it becomes very important to see whether we are not dealing with other causes of ascites in these patients. It's also important that in our country we rule out tuberculosis, because that's an important cause for the refractoriness of ascites in patients with cirrhosis. Now, the first step, which we most often forget, is to look at the dietary sodium restriction and the diuretic response. So I'll just tell you there could be three phenotypes of patients when you're managing and you're getting a patient of refractory ascites. So if you see that if all the patient is compliant with the salt and taking 2 grams or the 88 millimoles per day, but there is ascites reaccumulation, you need to look. So this is the first part in the evaluation, that you should look at the daily urinary sodium excretion. So if the patient is accumulating but the sodium excretion is 88 and the patient says that he is compliant, it is important that we increase the diuretic dose, and this will result in so you can optimize the dose of diuretics. However, in the other setting where the urinary sodium excretion is not there, this patient, we should not, or rather defer using diuretic, because there is a diuretic resistance here in this set of patients. And if you use diuretics, they are more likely to get complications. And these are the set of patients where there is diuretic resistance in the kidneys, and you should be looking for the second-line treatment options. The third set of patient is the patient who claims to be compliant, but is actually non-compliant. And this patient will be excreting more salt, but still accumulating ascites. So it is important that you ensure the adherence and compliance to the salt in this set of patients. Now, why we are talking about this? Because this is a very old data, and I think so we need to do more studies looking at the impact of diuretics on the circulatory dysfunction, the hormonal patterns and how it influences the kidney function in this set of patients. And this is an old study looking at the usage of two diuretics, the torsemide, which is a more potent diuretic than furosemide. And if you see here, 0 versus the 24 hours, even though the patient had urinary sodium excretion, but you can look at there was a worsening of the hemodynamics, there was worsening of the plasma renin activity and aldosterone. So diuretics can rather be harmful in patients who have refractory ascites. So what are the next medical options in this group of patients? So we know about the ANSWER study. This was an Italian multicentric open-label randomized control trial, but this looked at the uncomplicated ascites. So this was not refractory ascites. So these patients, where it was shown that giving high dose of albumin, 80 grams for 2 weeks, followed by 40 grams for 18 months, and they showed that 50% less incidence of refractory ascites and all the other liver-related complications happened in patients who were given such high dose of albumin on a long-term basis, but this was uncomplicated ascites. So can we achieve the same benefits in refractory ascites? This was not a RCT, this was a retrospective series in which the patients were given 40 grams of albumin per week, and this was all refractory ascites patients, and they were compared to the standard of care. And you can see here that patients who received 40 grams of per week of long-term albumin versus the standard of care not only had improved survival, but also reduction in all the complications. So this is one strategy which should be tried in these patients. But we also know about the hemodynamics, and this is a study from our center. This was done by Preeti. So what we aim to do here was that in refractory ascites, it is not just the effective hypovolemia. I'm sorry for this slide, it's too busy. But this was the poster which we presented this year at EASL, and she also got the best poster award for the study. So what we did here was we hypothesized that the refractory ascites group not only have effective hypovolemia, which could be counteracted by giving albumin, but also because the systemic vasodilatation is severe, here combining midodrine, which is a oral adrenergic vasoconstrictor, to albumin could be helpful. So one group received albumin in the same dose as the ANSWER study, and the second group also received a combination of albumin with midodrine. So when we looked at the outcomes of these set of patients, the midodrine, the mean dose was around 21. It was well tolerated with minimal adverse events. And we can see here on both the intention to treat and per protocol analysis, the group which received the combination of albumin with midodrine in refractory ascites showed improvement in the transplant-free and the TIPS-free survival benefit was observed. There was improvement. There was lesser incidence of acute kidney disease and chronic kidney disease. And all the liver-related complications were seen to be reduced in this in patients with refractory ascites. Now, when we look at the medical management, we know that these therapies are, we know that there is a limitation, and you have to consider options like TIPS or liver transplant early in the course of disease. Now, TIPS, we have seen from this individual, this is a very new data of individual patient meta-analysis, and this includes 12 control studies. So TIPS will reduce the portal pressure, which is the key driver of refractory ascites in these patients. So in this particular meta-analysis, which included almost 4,000 patients, and TIPS was controlled to the standard of care, and they also did a propensity score matching. So TIPS was done for different indication, and refractory ascites was one of them. So when they looked at the role of TIPS in preventing further decompensation, which included the development of ascites, variceal bleeding, hepatic encephalopathy, jaundice, renal dysfunction, so it was seen that the TIPS was able to reduce all these complications, the further decompensating events were reduced, and this also resulted in improved survival in these patients. So TIPS could be one strategy. But the challenges of doing TIPS in patients with refractory ascites is that the outcomes are not so good, and the patient selection remains a priori. The timing, the risk of liver failure, hepatic encephalopathy, and cardiac decompensation is something which we have to be very careful about, because these are very sick patients and they can go into these complications. So what is the appropriate therapeutic window for TIPS in patients with in ascites? In fact, we can see that refractory ascites is a very late stage and tips should be done as early as possible wherever you're feeling that there is a refractoriness of the therapy. So the timing of tips should not be too late when the patient has gone and finished all the options, but it should be timed early on in patients with ascites. And this is some new data which I'll show again. So this paper, this looked at the TIPS outcomes, and this TIPS was done in patients with refractory ascites. This was a retrospective cohort of 128 patients, of which at 3 months they were classified. The patients who had a control of ascites, they were almost 74%. 26% of these patients had persistence of ascites, that they still required therapeutic paracentesis or diuretic treatment. So when they looked at this set of patients and they found that what predicted the lack of control of ascites, it was the cumulative paracentesis frequency and the baseline creatinine. So the number of paracentesis, so the later that you're doing TIPS in the refractory ascites patients, the more the number of paracentesis, the more likelihood is that the patient may not respond to this therapy. And this can also again be seen that patients who have already gone into renal dysfunction, they are less likely to respond to TIPS. And you can see here that if you have control of ascites after TIPS, the survival was also better for these patients. So how do we do a risk prediction? So we know about the MEL score, the MEL sodium score, the child puke, which we've been using to identify patients who are less likelihood of developing liver failure or other complications post-TIPS. But again, this is a new index, the Freiberg index, and this was developed from a German multicentric cohort of patients. 7 German centers were included. Again, this was retrospective, but a large cohort of patients, 1,871, which they divided into a training set of 80% and validation set of 20%. And they also looked at the subgroup of patients of TIPS who had a preemptive TIPS placement. And this Freiberg index was on multivariable analysis, was developed using these 4 factors: the age, which is an important factor while considering TIPS, bilirubin, albumin, and serum creatinine. And they showed that this was able to give us a better stratification as compared to the routine liver severity score, but it was not able to identify patients who would do poorly after a preemptive or an early TIPS. And we can see here the survival curves, that patients who underwent, and those patients who underwent TIPS and had a high Freiberg index, that is more than 0.92, you can see here in both the training and the validation cohort, the median survival was just 5 months and 3 months respectively, as against 48 months for the group which had a low Freiberg index. So this is something which we should try and see, and whether it is applicable to our patients as well. Now, the other important factor which predicts poor outcome after doing TIPS in refractory ascites is sarcopenia, because we know that, again, there is a risk of hepatic encephalopathy. So this was a study which was done from our center, 210 patients, retrospective series. 71% of these patients had refractory ascites. And all these patients who had CT scans within 3 months, we calculated the skeletal muscle index to identify the prevalence of sarcopenic population in this group. And we found that almost 1/2, that is 53%, were sarcopenics based on the CT skeletal muscle index. And we found that when we followed up these patients, almost 1/3 of these patients developed hepatic encephalopathy, and a pre-TIPS higher serum ammonia and the presence of sarcopenia was what determined not only a higher risk of the first hepatic encephalopathy, but also a risk of multiple episodes of hepatic encephalopathy in these patients. So again, we found that age was important, lower serum albumin, and sarcopenia was one factor which is again very important to be assessed to identify which set of patients will go on to develop recurrent hepatic encephalopathy. Now, assessment of nutrition and frailty. Now, these are two very important. These are mostly ignored in the clinical practice, but in refractory ascites, it is very important because most of these patients, they have been put on a salt-restricted diet, and they will try to restrict calories as well. They will restrict fluid. So it's very important that a good nutrition protocol, a prescription should be written for these patients, a good calorie intake, and with a good amount of protein, as well as these patients are mostly sedentary. And slowly they go on to develop they become frail. So it is important that you put them up into a good exercise protocol, which should include both aerobic and resistance exercise, reinforce these important features which will improve the sarcopenia and frailty in these patients. And the role of branch chain amino acids, again, looks very promising, but again, there is no large randomized controlled trials to suggest the benefits in refractory ascites. The other major complication that we are worried about in refractory ascites is the risk of cardiac decompensation. And cardiac decompensation, again, is a frequent complication, and in this particular study, it was reported in almost 20%. So 1 in 5 was developing cardiac decompensation. This was, again, a retrospective series which aimed to look at the risk factors for cardiac decompensation, because cardiac decompensation, again, was an important factor which was predicting survival in patients of refractory ascites who were taken up for TIPS. And the factors that were associated with cardiac decompensation included a prolonged QT interval, a pre-TIPS BNP level above 40 or an NT-proBNP above 125, elevated E by A ratio, and left atrial dilatation. So based on these factors, they proposed an algorithm, and this again can be very easily followed in our patients as well, the Toulouse algorithm, which they suggest that at the first set, if you have to predict the risk of cardiac decompensation, we can look at the BNP or the NT-proBNP levels. If the pro-BNP and NT-proBNP levels are normal, we just need to do a simple transthoracic cardiac echography to rule out pulmonary hypertension, aortic stenosis, and the left ventricular ejection fraction, so organic cardiac disease. And if this is not there, these patients almost have a 0% risk of developing a cardiac decompensation. However, if your NT-proBNP or a BNP levels are high, this group of patients is where you should suspect cirrhotic cardiomyopathy, and you should do a complete transthoracic echocardiography, look at the E by A ratio, E by E prime ratio, the left atrial diameter. All these factors are important, because if this is going together, the risk of decompensation is almost 100% in these patients. So from here on, after we've learned about cardiac decompensation, we move from another strategy which can be used to have a success with TIPS in refractory ascites. And this is not to go with larger stents, but a smaller diameter stent, maybe 8 millimeter, which is better, because if you put larger stents, these are the patients where you will achieve effective portal pressure reduction, but the complications are much higher. So this was an important study which again looked at the predictors of 5-year survival post-TIPS placement, and their aim was to look at the size of the stent. So TIPS was dilated to 8 millimeter versus 10 millimeter, and they found that if you do in patients who were sicker, so patients who were having jaundice, bilirubin above 3 or refractory ascites, they were the ones where they had actually done a 8 millimeter dilatation, and they found that this was an important factor in this sicker group of patients in predicting survival benefit post-TIPS, as was the renal dysfunction. So again, renal dysfunction, age, and all these factors are important, and there is where we should not be using TIPS. Now coming to the alpha pump, we know that alpha pump is not available in our country, but very extensively used in Europe and US. And this is a subcutaneously implanted and a battery-powered device which moves the ascites from the peritoneal cavity automatically to the urinary bladder, and it facilitates removal of fluid by urination. So this alpha pump is again used for patients where the patients are unsuitable for TIPS, where the patient is not a candidate for TIP because of portal vein thrombosis, or there is associated cardiac disease, or previously has failed TIPS, where you can use this, because this will not improve the pathophysiology, but it will just enable the reduction in the need to travel to the hospital setting for the large volume paracentesis. So let's look at the data for the alpha pump, and this was a systematic review with the meta-analysis, which included 9 studies, 8 were case series, and 1 was a randomized controlled trial. And as expected, all these studies, so 62%, 2/3 of these patients did not require any LVP after the placement of this device in the peritoneal cavity. And this was very quickly seen. The results were observed at a median of 2 months after placement. However, we know that alpha pump is just taking out the ascitic fluid from the peritoneal cavities. So obviously, because you're placing an external device, there is a risk of infection. So risk of infections, both spontaneous bacterial peritonitis and urinary tract infection was much higher. And because you're not replacing it with albumin, so slowly these patients, so almost 1/3 of these patients do develop acute kidney injury, because we're not supplementing, and none of these studies had supplemented long-term albumin in this patients who were placed with alpha pump. And this was a very elegant study again, which looked at what happens to the hemodynamics, renal function after placement of the alpha pump in a set of 10 patients. And you can see here that all these patients all had reduction in GFR after placement of this pump. There was an increase in the plasma renin activity and norepinephrine levels, again signifying the circulatory dysfunction that is accompanied by the placement of this alpha pump. Now, liver transplant. We do not send our patients for liver transplant in refractory ascites on a timely basis, because we feel that the MEL score is 10 or 12. But what we need to remember is that these patients, even with the low MEL scores, have very high incidence of death and complications and hospitalization. So liver transplant remains the first choice after a proper optimization for refractory ascites before we consider any other therapy, and especially if the patient has an episode of spontaneous bacterial peritonitis, has already started to develop hepatorenal syndrome, non-HRS AKI. So all this set of patients should be referred to the for the liver transplant. And you can see here that these patients, most of them will also have significant renal dysfunction, and they may even be candidates of a simultaneous liver kidney transplant. So it's important that we consider this therapy early on rather than late in the disease course. Palliation is another important aspect, because many a times we see elderly population, patients with concomitant comorbidities, and you cannot consider any form of definitive therapy in these patients. So this is a randomized control trial. So the palliative option remains long-term placement of abdominal drains versus putting these patients up into repeated large volume paracentesis. So this was a 12-week feasibility, non-blinded randomized control trial, which looked at the outcomes of the placement of these palliative long-term abdominal drains. And you can see here why we are saying palliation, because when they designed this study, 15% of the patients had died at the time of screening itself, and 40% had died within 4 weeks of recruitment. So it's a palliative option, because these drains are not definitive. Again, they are associated with a lot of complications, but yes, in a palliative setting, this can be considered as a good option. And this is another series of patients, again, looking at the palliative placement of the intra-abdominal drains, and they showed that the median survival, again, was just 29 days. So very sick patients will have to travel. That set of patients, these drains, because we do not have alpha pump, could be a very important, because that will reduce the cost and will improve the quality of life of these patients who do not have a definitive option. Now, last is the contentious issues. And we're struggling to identify whether we should be using or should not be using beta blockers in the management of refractory ascites. So we know the benefits of beta blockers. It will reduce the bacterial translocation. It will improve portal hypertension, which is supposedly the key driver of refractory ascites. But the therapeutic window is still not known, whether you should be using beta blockers. And so mixed data is there. But the original paper, it was by Surst, and this was a prospective series of patients where it was shown that the beta blockers are detrimental in patients with refractory ascites. The survival was just 5 months versus 20 months, and the patients were not given beta blockers. And we can see here that beta blockers were associated with more renal impairment in these patients, development of hyponatremia, and worse survival. But when you look at the cohort, the beta blocker group was much more sicker. We can see here, because this was not a RCT, and you can see here that the patients who received beta blockers already were more hyponatremic. They had severe portal hypertension, larger varices, and higher bilirubin. And the beta blocker dose that was given was very high. So almost 50% had received 160 mg of propranolol. So this is something, again, that's why the entire debate arose, and this paper was subsequently debated in various meetings. And subsequent, the same group had shown that in the same, a very elegantly done study in patients with refractory ascites, patients who were given beta blockers, they showed that how these beta blockers were detrimental because they were influencing the cardiac performance. So the cardiac inotropic function was reduced and the development of PICD with the paracentesis was much higher in patients with refractory ascites. And this is some new data again, comparing the performance of beta blockers in patients who had diuretic responsive versus refractory ascites. So 18 patients and 20 patients, small set of patients, but a very detailed evaluation of cardiac and renal function showed that if you give beta blockers in refractory ascites, the cardiac performance declines, even though there is decline in GFR in both sets of patients, diuretic responsive and refractory, but renal functional impairment was noted, and particularly in refractory ascites group. So we need to be very careful. We do not know which patients, but a detailed cardiac assessment may be the same strategy to choose tips may be followed for identifying the use of beta blockers in these patients. So I would like to summarize by saying refractory ascites, timely liver transplant, improves outcomes, should be considered. Complicated ascites, which is where diuretics are very harmful, and we should generate more data, what appropriate dose of diuretics, how it is harming the renal function. LVPs, yes, is an important way of managing these patients. Early tips is something, again, RCTs are required to see that after how much TAPS you should consider and randomize these patients for tips. Long-term albumin combined with vasoconstrictors, nutrition and fertility assessment, role of branch-chain amino acids in these patients. And again, the right selection of beta blocker where you can give in refractory ascites is something needs to be seen in prospective studies. Thank you.